you very much. Thank you very much. I hope you had a good lunch. It's a pleasure and an honor to be here. I would like to thank you, especially Dr. Thanasis, Professor Picolis, for the invitation. It's not my first time in Greece. Professor Picolis was saying that I look young, but first time I was in Greece was 37 years ago, and I still remember the plaka, so you can do the calculations. I'm a trauma surgeon by training, and I'm also an emergency physician. And I spent a couple of years in the Navy, so I did my time in the military for not only within the Navy, Portuguese Navy hospital, but also on board our frigates and sailing around. So I feel very comfortable when I come to a military setting to talk about combat casualty care and what we should do in the field. This is a very challenging topic, talking about liquids and fluids, because as you will see, in the last couple of years, things changed so much, but so much, and we're now going back to the basics, and that's what I'm going to try to explain to you. I'd like to start by saying that war is a real epidemic of trauma, and wars have been the growing grounds for a lot of evolutions in terms of medical care. Specifically, if we start with the First World War, and in those days, we already knew that shock was a result of blood loss and plasma loss. Although there was no capacity in those days to provide blood, especially in the field. So there were some ideas about colloids. Basically, they were using saline solutions, and believe it or not, they were not always IV. They were putting through rectal, as a rectal crisis, or subcutaneously under the breasts. That's how they used to infuse fluids in those days. By the end of the war, there were some experiments in warm whole blood transfusions, because there was absolutely no capacity to store blood, so you had to collect and immediately deliver it. In the Spanish Civil War, just a couple of years later, it became practical to store blood, because the citrated solutions were being developed, and so it was possible actually to collect blood, keep it for a couple of days, and then transfuse it later. This was the first time this was done. And then when the Second World War came, it was clear for everyone that whole blood was the resuscitation fluid of choice. So if you had an injured soldier, he needed blood. However, all the logistic problems that were associated with collecting blood and transporting blood and distributing blood made it almost impossible to have. So during the war, basically what they had was plasma, albumin. In those days they were using a lot of albumin in these patients because they were easy to store and transport. And for the first time, the idea of freeze-drying plasma, so FDP, came along. So you have plasma as a powder, and you just add some saline and you infuse it. And this was a great idea already in the 40s. The problem was that after the war, there were a very high number of cases of patients infected with hepatitis B that had received this freeze-dried plasma. And today, when we look back, we know exactly what happened. The problem was that this plasma was being collected from a pool of almost 10,000 different donors. So it was very hard to be sure that, and in those days also the techniques were different, to be sure that that plasma was not infected. So because of that, the whole idea of freeze-dried plasma was left behind for almost 60 years because of that specific problem. More recently, if we go back to Operation Desert Storm in the early 90s, that's when we started to hear about the crystalloid-colloid war, which one is better. And in those days, the first clinical trials actually showed no advantage between crystalloids over colloids or whatever. So colloids ended by being chosen because they occupied less volume. Even from a logistic perspective, a whole box of colloids could treat more patients than the same box of crystalloids. And so for that reason, colloids started being used more and more. And for the US Army, for example, the X-stent became the recommended pre-hospital option if you didn't have any blood. And this was the early 90s. Now, beginning of the century now, when we started the global war on terror, we started hearing about the concepts of hypertensive resuscitation and ratio-driven resuscitation, where you give one plasma, one red blood cell packed. In those days, we also started hearing about the importance of hemorrhage control, of the importance of fighting hypothermia. The first hemostatic dressings started to be used, and tranexamic acid for the first time was being used in the field, and this was already almost 20 years ago. Now, a bit more recently, during the Afghan war, a few other concepts came along. Not only the damage control surgery that we had already heard about it, but the damage control resuscitation. So giving plasma and red blood cells before the patient reaching the hospital, permissive hypotension, so leaving the blood pressure low, minimal crystalloids, and these were the trends early in the just 10 years ago. So now that we saw a little bit of what happened in the history, let's go back a little bit to the physiology and understand which fluid and how do we actually need to use these fluids the best way. So if you have a trauma patient, and especially if we're talking about penetrating trauma, it's quite sure that hypovolemia may happen. Now, if you have hypovolemia, your tissues will receive less blood, so you have tissue hypoperfusion. And if you have tissue hypoperfusion, then you have less oxygen being delivered to the cells. Now, these, of course, makes the shift in the cell, because if the cell does not have oxygen, so it goes from the traditional aerobic metabolism to anaerobic metabolism. This simple fact gives you lactic acidosis, because lactic acid is one of the products of anaerobic metabolism. Now, anaerobic metabolism has another problem, is that if you breathe aerobically, you produce something like 32 ATPs per cycle. If you go into anaerobiosis, then you will have only 2. It means you produce less energy, you produce less heat, you go into hypothermia. Now, hypothermia then will be, of course, even, I would say, enhanced because of the adrenergic vasoconstriction. And so you already have here, because of trauma, lactic acidosis and hypothermia. Now, if you have hypothermia, then all your enzymes that work in the clotting cascade will start to failure, because they need to work at 37 degrees. So if you go below that temperature, those enzymes start to failure. platelets will also not work the same if you go below 37 degrees. And fibrinolysis also will start to happen. So we have trauma-induced coagulopathy. Now you can already see here something is building up. So you have hypothermia, lactic acidosis, coagulopathy. Now it doesn't end here, because lactic acidosis actually leads to decreased myocardial contractility, which in turn will lead to reduced perfusion. And if you have reduced perfusion and coagulopathy, you cannot oxygenate the tissues. So we close the cycle. And basically what we're talking here is what we commonly call today the lethal triad of death of trauma patients, which is lactic acidosis, hypothermia, and coagulopathy. And this is what we need to fight in the field. Now, seems clear that hypovolemia leads to all these three factors of death: lactic acidosis, hypothermia, and coagulopathy. So the answer to hypovolemia would be fluids, definitely. But what kind of fluids, and what are the concerns when you start thinking about fluids? One of my major concerns when I think about fluids is the pressure effect. So the reason why once we start bleeding, our pressure drops, it's a physiological mechanism. It prevents blood to, basically prevents you to bleed to death at the high pressure. So if the pressure is low, you're bleeding at a slower rate. It's probably the same mechanism that happens, for example, if your brain is not getting enough oxygen, you faint. And when you faint, your head will be at the same level of the heart. So it becomes easier to receive blood because you are at the same level of the heart. Now, hypotension is actually a physiological mechanism that will help us go through the process and will allow, for example, for the clot to form and to block the bleeding artery or the bleeding vein. Now, if we increase the pressure too much, and most of the studies that have been done show that above 1994 millimeters of mercury, the clots actually start popping. So like a champagne bottle, you just increase the pressure and the pop close. So the effect that you were gaining from the low pressure actually is lost, and you start rebleeding. So when we think about fluids, always keep in mind the effect of pressure. We don't want too much pressure, especially if we didn't control the hemorrhage yet. Okay, and if we're talking about the field, most of the times at this time we didn't had good control of the hemorrhage. Now the other problem is what was lost. So if you have cholera, you're losing water and electrolytes. If you are dehydrated in the desert, you're losing water and electrolytes. So ideally, you replace what you lose for the same with the same fluid that you lost. So if I'm losing water and electrolytes, I should replace with water and electrolytes. Now, if you have a trauma patient, especially in military casualty, gunshot wounds, what do you lose? You're not losing water and electrolytes. You're losing blood. So blood is probably the right answer to replace. It's like your car. If your car is losing oil, you don't replace with water. You replace with oil because that's what it needs, right? So paradoxically, we have been replacing blood with other fluids that are not blood. And if you think about the potential side effects of many of these fluids, let's start with crystalloids. If you give 1 liter of normal saline to a trauma patient that is bleeding, 1 hour later, you only have intravascularly, you only have 200 ml. The other 800 milliliters are already in the extracellular tissues, because the only molecule that actually accounts for the osmotic capacity of crystalloid is sodium, and sodium clearly goes throughout the tissues. So you give 1 liter of crystalloids, and 1 hour later there's only 200 ml inside. The other 800 are everywhere, are in the lungs, are causing congestive heart failure, probably within the gut, which will lead to a prolonged ileus. You will probably be having a delusional coagulopathy, and you will restart bleeding. So many complications that arise from this crystalloid resuscitation that today is almost being considered like the last resource. Now, if you look at colloids, they do have some advantages. If you give 1 liter of colloid to a patient, 8 hours later, you still have more or less 1 liter intravascularly, because the big molecules that account for the osmotic pressure, they don't go through the tissues. I mean, there are some reports on the risk of having acute kidney injuries by colloids, although these reports, most of them are actually contradictory. So you will see it's not something that it's clearly established. The other product that we have is blood. Now, blood has, of course, the infectious risk if not properly screened. And of course, we know that there is a risk of a transfusional reaction or allergy that happens in 1 every few thousand patients. Now, the interesting thing is that we moved from crystalloids, and I remember when I started doing pre-hospital work almost 20 years ago, the guidelines were clear. You have a trauma patient, you get 2 IV lines, and you put 2 liters of normal saline inside. And this was, I mean, no discussion about it. Now, today we know that actually we were increasing the mortality of these patients for all these reasons and some others. So we were completely wrong just 20 years ago. And then we moved a little bit to colloids, and especially I would say most armed forces moved into the colloids because logistically it was easier to carry, and they occupy small volume, small space, so you can treat much more patients with the same volume. So everybody was changing into colloids. But then they realized that actually you're not losing colloids, you're losing blood. So now we started again thinking about blood. Now there is this beautiful quote from Lieutenant Colonel from the U.S. Army that says, "The historic role of crystalloids and colloid solutions in trauma resuscitation represents the triumph of hope and wishful thinking over physiology and experience." So somehow hope and wishful thinking ruled for, I would say, during the 80s and the 90s and even the early beginning of this century. And now probably we're going back for the right solution. So if you take blood as a whole blood and you centrifuge the blood, basically you will get plasma, you'll get a buffy coat of platelets, and you get red blood cells. And this is what we should be giving to our trauma patients. Now the problem is that plasma and red blood cells, they require to be refrigerated. So this is another logistic concern, that if you are a force being deployed somewhere, means you need to take a refrigerator with you to have your platelet, your plasma, and your red blood cells. Platelets, on the other hand, they need to be constantly shaken and stirred, so it's not manageable to have them in the field. So let's forget about platelets. And let's think that we still have frozen plasma and red blood cells. Now, what I would say was probably one of the greatest advances now in the last couple of years is that we went back to freeze-dried plasma. Now it's being done in a completely different way than it was done in the Second World War, much more safe. Actually, the risk of infectious disease transmission is probably zero or around zero. Very easy to carry, very easy to store. You can have freeze-dried plasma stored at room temperature for 2 years, which is amazing. If you compare it with a fresh frozen plasma that needs to be kept at minus 18 degrees. So from a logistic perspective, this is what we should be carrying now, freeze-dried plasma. And the advantage is that when you use plasma for the resuscitation, you're actually bringing all the clotting factors that you need to stop the hemorrhage. So you, on one side, you avoid the dilution of coagulopathy. It replaces all the procoagulant and anticoagulant proteins. It repairs the endothelial function, and at the same time has the inflammatory effect of plasma. So if you think that trauma-induced coagulopathy, and I showed you how you get to the coagulopathy, is already associated with a 5 to 6-fold increase in mortality. So coagulopathy is what we need to fight when we have a trauma patient in the field. And probably plasma is the right thing to do it. So I think the goal of the whole presentation today was basically to come up with an algorithm, because the title of the presentation was fluids and in which settings. So I'll give you the algorithm now, the way I see it. If you have a trauma patient, you have two options, and you are in the field, you have two options. Are there signs of shock? And to be honest, in the field, signs of shock are very simple. It's radial pulse. If you don't have a radial pulse, you're in shock. If you have altered mental status, you are in shock. If you become unconscious, probably you are in shock. So let's say that you have no signs of shock. So if you don't have any sign of shock, no IV fluids. No signs of shock, you don't need IV fluids. You can drink water, you can drink liquids if you want to, but no need to provide fluids for a trauma patient that does not show signs of shock. Okay, let the nature do its job. You will still do the ABCDE, so you'll still go for the airway, for breathing, circulation. You'll still work on the hypothermia, and if you have tranexamic acid, give it. If you use it in the first 3 hours, it may make a difference. Okay, after the first 3 hours, probably doesn't make anything. It's like giving adrenaline to a patient in cardiac arrest 2 hours after the cardiac arrest. Probably doesn't make any difference, right? So tranexamic acid, within the first few hours, may have a role. If you have it, give it. If your patient has any sign of shock, then we should give him blood. And ideally, you should have fresh, warm, whole blood. This is what he lost. This is what he should be receiving. So if you have it, this is the first line. Now, you tell me, well, we don't use fresh, warm, whole blood. Okay, so second option is you have the three components. Okay, so you have plasma, you have red blood cells, and you have platelets. So you give 1 to 1 to 1. And this is your second line option. Okay, if you don't have the fresh warm blood, let's go for the second line. But you may say, well, you know what? We don't have platelets in the field. It's very complicated to have them. Okay, so you have plasma and red blood cells. So if you have plasma and red blood, give plasma and red blood. So you are on one side you're fighting the coagulopathy with all the clotting factors that plasma brings, and you're bringing the oxygen carry capacity of the red blood cells. So we are in the right direction. Now if you say, well, I only have one or the other. Well, if you only have one or the other, I'll go for plasma. Okay? It's more important, actually, to try to stop the hemorrhage than to bring additional oxygen carrying capacity. So if I only have one thing to do, I will go for plasma. Now if you don't have any blood products at all, then I'll go for a colloid. And not albumin, but anything like the HES. And you have a lot of them. You have the Voluvan, you have Extend. I don't know which brands you use around here, but these are the ones that actually you can use. If you don't have anything else, crystalloids, maybe. But I would say instead of giving crystalloids, I would rather raise the legs of my patient, and I'm more or less giving him 1 unit of blood. So I would probably not go into crystalloids. And if you're using crystalloids, then Plasmolite is better than Ringer, and Ringer is better than normal saline. Okay? So this would be my approach. Now, the thing is, where is it available? And this is the next big question, is where do you find these products if you are on a military mission? Will you find it at the role 1 level? Well, usually at role 1 level, you'll probably have today, most of the times, colloids and crystalloids. That's what you find. Probably at the role 2, you may find some plasma red blood cells eventually. And at the role 3, probably you will have access to the platelets also. So this is how it is today. What I think that it should happen in the future, and actually some of the armed forces in the world are already moving in that direction, is that plasma, especially freeze-dried plasma, is available at the role 1 level. So the medics at the smaller unit size already carry them 2 or 3 bottles of freeze-dried plasma. And then they take 100 milliliters of normal saline just to reconstitute the plasma and administer it. So this will be probably the best strategy. The second best strategy is if you are evacuating patients from a role 1 facility to a role 2 facility, if during transport you can provide plasma and red blood cells. This was the British have been doing this in Afghanistan for a couple of years now. Well, not now they're out, but until recently. So all the helicopters going for the evacuations, carrying the medical team, they were also carrying plasma and red blood cells. So you start to give plasma and red blood cells as soon as you can. And if you can do it during transportation, that's where you should do it. Then, ideally also, already at role 2, you should be able to have the rest of the components, or eventually fresh warm blood again. And this is, I would say, the most simplistic approach that I can give to you in terms of what fluids to use and where to use them. The goal is clear. The goal is you give enough until you get a radial pulse, until you have improved mental status, or until you have a systolic blood pressure of 80-90. We don't want to we don't want to pop the clot. So no more than this. Once you gain surgical control of the hemorrhage, then you can give whatever you want. Okay? Then it's not bleeding anymore. Everything is under control. But until you get there, these are our goals. Not more. Thank you very much.
Thank you, Dr. Nelson. Any questions?
My name is Dr. Thank you for the excellent speech. You haven't said anything about age.
About?
Age groups, hemoglobin-based doses.
Yeah, well, when I had to take some decisions in terms of how far I wanted to talk into some areas. I would say that at the level of the field operation, there's not much that we can actually have available today that is already demonstrated his capacity to actually to increase survivability of these patients. I mean, oxygen, yeah, I understand. I mean, it's just that at the field level, so if you're talking about the medic, the role 1 level, the role 2, I don't know anyone in the world who's actually using it right now. Do you have any?
No, I just know that I'm using it in the past. They perhaps abandoned by certain others.
Yeah.
Because of the so
because
cheaper, perhaps more easier to carry.
Yeah, I don't think I'm trying to think if I know of anyone today who's actually using it, and no, I don't think so. I mean, right now, what I summarize here, I would say it's the most simplistic approach that one can have. Just to give you an idea, for example, in Israel, for example, the paramedics in a civilian setting on a daily basis already carry with them tranexamic acid and freeze-dried plasma. Right? And this is at the paramedic level, at the ambulance, at the scene of the accident. They start immediately providing that. And clearly, the first results that they are bringing out today shows increased survivability for these patients. So I think that's the right strategy for the future.